I want to sort of shift our attention now to more advanced disease. And Mike, I'm going to kind of give you the lead on this. You know, we've mentioned already this idea that precision medicine's here to stay, molecular profiling is appropriate. Tell us in your stage 4 colon cancer patients what your strategy is. What do you got to know? What do you like to know?
Yeah, I think it's clear that at a minimum we need to know, of course, KRAS, NRAS, BRAF, and mutational status and MSI. If we could just get all patients to have that done, I think that would be very important, because clearly it's not done. We see people still come in that have had maybe some KRAS testing, may not have had NRAS, BRAF occasionally is done. Maybe that'll change with actual data for therapeutic options for those people. Because there's a lot of other mutations that could be present, but we're not really acting on those in the first line. We may subsequently, I think that you could argue that alone is adequate, and then looking for the others later on is
And so your all's practice is to do that sort of smaller panel first, and then maybe consider broader panels later?
Yeah, I mean, a lot of this runs into the research agenda and so on, where we have a lot of interest in circulating tumor DNA and so on, and people are getting analyzed for a larger panel often. But I would say the general practice for a patient who's not involved in research would just be that limited panel.
I just want to make one sort of basic comment, is that if I see a breast cancer patient, the first line of the HPI says such and such a year old, ER, PR, HER2, right? And no fellow would ever present a breast cancer case without starting there. And I think on some level, we all need to do that in our world, where if it's not in that first line, the MSI, RAS, BRAF, and that's obviously missing, right? And so it's not down in the thread, it's not in some bad fax, copy in the EMR, that it's right there, and that's how you start talking about the patient.
Well, let me make the case, though, for adding HER2 to that panel.
Yeah.
And I think I want to know that from day one, actually, along with everything you said, because HER2 will help with two things. Will help certainly, as we understand a little bit more, that these HER2 amplified tumors may have less benefit from EGFR inhibitors, mostly from retrospective analysis, but it makes also scientifically makes sense. HER2 is a driver of resistance to EGFR inhibition. I mean, they belong to the same.
I think a lot of people aren't really aware of that.
No.
That when they're starting an EGFR therapy, in the absence of knowing about HER2, right?
Yeah.
You really need to know that.
I think you do. It enters into the equation. In fact, it makes your EGFR inhibitor work better, because you're refining those who don't,
even further
in some ways.
enriched.
So it's
Maybe
doesn't-
I mean,
same is true for
the
BRAF.
guidelines just got changed in regards to allowing you to consider utilizing Herceptin for your HER2 positive patient. So.
And yet this is still a research question. I mean, there are randomized trials actually
Correct.
addressing this right now.
I mean, we had that was impressing European data, and now we're trying a different approach to the United States, and yeah, definitely.
Yeah, and I think again that helps you with planning for your patient for the clinical trial as well. So rather than wait 2-3 lines of therapy, you skip to second line with a HER2 combination strategy, hopefully on a clinical trial.
Well, what percentage of the time have you seen people switch from HER2 non-amplified to amplified after therapy, though?
Unusual, but it happens.
Yeah.
I think it's a very small percentage.
Yeah.
The Italian data would say it's up to 20 to 30%, but I think in reality it's closer to 5, maybe
Yeah.
10%.
Definitely.
Well,
I think it's
5 to
closer to
10.
5.
At least in my population.
Well, we don't yet have a culture of rebiopsy, of reanalysis, right? I mean, they do in breast cancer, they do in lung cancer. Should we, Mike?
Well, so because we have circulating, and I'm sorry to keep harping on circulating tumor DNA, but it's certainly an interest of ours, that offers you the opportunity to rebiopsy in effect. I agree with you that put somebody through an additional liver biopsy is not desirable for many people. Maybe not desirable for us as oncologists to recommend it to people. But we do know that there can be changes, particularly people treated with anti-EGFR therapy, that unusual mutations can arise, the rare RAS mutation in a subclonal fashion that didn't exist before the therapy, binding site mutations in EGFR that can take can take months to resolve, even after you stop the anti-EGFR
And
therapy.
with our targeted therapy, I'm seeing more mixed responses where a lot of the disease is under control, but one lesion is growing. And
Yes.
I'm tempted to biopsy that lesion to see if they're
Yeah.
Radiate it.
and radiate it, right? But keep your systemic therapy going, play whack-a-mole. That's
But I
just
think
kind of the way
that's-
I'm
I
thinking.
agree. I mean, we've
Everybody
all
in
done
on
that.
But I think that's
Periodically?
No, I think that's an important aspect of what we do. So when we're thinking about a biopsy versus a liquid biopsy, if there's only one tumor that's acting bad, that would be a good target. If the patient has 10 lesions and they're all acting bad, which one do you biopsy? There's a lot of heterogeneity. This is where I would favor the liquid biopsy piece.
Tony, when are you doing your analysis? Is this right from the beginning? Are you starting and then waiting and then getting it later?
The moment I'm meeting the patient, I want everything. That doesn't mean I would recommend that to be done on a wide basis for every patient in the community. I'd say get at least the ones we've already discussed, the RAS, RAF, MSI, and HER2, maybe even the NTRK fusion as well. So you're just informed if you ever find it.
Big institutions do their own assays, right?
Well,
No? No?
We have it available, but we send it
Are you
on.
basically partnering with somebody when you do this?
Well, at
and doing
MD
broad profiling?
At MD Anderson, we were doing it ourselves, but I know at other institutions, they are sending it out.
So we have our own, but we send it, and the reason for that is one of the challenges is primarily reimbursement issues. Our own costs quite a bit of money. We're trying to figure out a way about cutting it down for the patient. The companies that are doing it before we ever even thought about it, have become quite privy to how to deal with the reimbursement issues, and that actually is one of the limiting factors of not just, running with just our own.
Yeah, we've got 3 main tissue-based companies that are really out there. We've got one major liquid biopsy, but there's others. There's a bunch. So you have strategic partnerships. They're not all created equally, right? They're different. They do different things, and it changes day to day.